Hello, my name is Dr. Kamran Chaudhary. I am pulmonologist and today we will be discussing about bronchoscopy and its guidelines, what to do and what not to do. So bronchoscopy is a minimal invasive procedure that is used to visualize airways and bronchial segment. Fiber optic bronchoscope was first discovered by Japanese scientist Shigeto Ikeda in 1966. Its use for human was started in 1968. Indication for bronchoscopy. We divide it into diagnostic and therapeutic. Diagnostic indications such as diagnosis of lung cancer, staging of lung cancer, vocal cord palsy, persistent cough, immunocompromised host, immunocompetent host. Therapeutic such as removal of secretions, endotracheal tube intubation, tumor debulking, stent deployment. Bronchoscopy suite setup. It should be done in dedicated room and room should have all equipment for patient monitoring and resuscitation. Bronchoscopy room should have dedicated disinfection and washing area. Staff protection. Bronchoscopy should be done by wearing PPE and N95 mask is recommended if suspicion of mycobacterial infection. All healthcare worker to get influenza and hepatitis B vaccination. Pre-bronchoscopy hematology. All patient undergoing bronchoscopy should not get routine investigation. Only high-risk patients such as CKD, CLD or on anticoagulants should get routine investigation done. A minimum of 20,000 platelet count is recommended for BAL and 50,000 for TBLB and ABB. BAL can be performed in patient with platelets count less than 20,000 after careful risk-benefit and oral route is preferred. Antiplatelet and anticoagulant agent. Antiplatelets such as clopidogrel, pasugrel, ticagrelor should stop 5 days before if planned for TBLB or endobronchial biopsy or TBNA. Warfarin should also be stopped 5 days before. Newer oral anticoagulant should be stopped 2 days before if patient on anticoagulant. BAL should be done careful risk-benefit analysis. Antibiotic prophylaxis and good clinical practice. No need for antibiotic initiation before bronchoscopy. Written and informed consent to be taken before. 2-hour clear fluid and 4 hours of light meal fasting is recommended before bronchoscopy. All patients should have IV access until fit to discharge. Patient monitoring during procedure. Continuous SpO2 BP pulse rate to be monitored during procedure. ECG to be monitored in patient having history of arrhythmias. Supplement oxygen to be given if SpO2 less than 90% or SpO2 fall more than 3%. Bronchoscopy to be done in supine position. Both oral and nasal route are preferred and oral route if thrombocytopenia or foreign body removal. Premedication sedation. Bronchoscopy can be done without sedation. Sedation can be used to improve patient tolerance. Sedative agent recommended are phenytoin, midazolam, dexmed, propofol. All patient receiving sedation should have strict monitoring of BP, heart rate, SpO2. Topical anesthesia. 2% xylocaine jelly is used for nasal anesthesia. 10% xylocaine should be used for posterior pharyngeal wall anesthesia. 3 to 5 puff are used. 1% xylocaine to be used as Vigo spray technique or cricothyroid injection. Total lignocaine dose should not exceed 8 mg/kg. Bronchoscopic sampling. In diffuse lung disease, bronchoscopy should be done from right middle lobe and lingular lobe. In PCP or cytomegalovirus infection, BAL to be done from more than one lobe including the upper lobe. In focal lesion, BAL to be done by HRCT guidance. At least 100 ml of saline should be instilled and it should not exceed more than 200 ml. Negative pressure applied for suction should be kept less than 100 mmHg. Bronchial washing and brushing. For visible lesion and suspected malignancy, bronchial washing and brushing should be obtained and 2 to 4 sample of bronchial brushing to be taken. For non-visible and peripheral lesions suspecting malignancy, brushing or BAL can be performed fluoroscopic guidance if facility available. BAL cell block is recommended in suspected malignancy. Sequence of sampling. TBNA to be the first procedure followed by bronchial washing and lavage followed by bronchial brushing then endobronchial biopsy. In diffuse lung disease, if BAL is planned for cellular analysis, it should be the first procedure. Transbronchial needle aspiration. Conventional TBNA can be done in lymph node size more than 1 cm in subcarinal and paratracheal and more than 2 cm for hilar and interlobar lymph node. If lymph node size is small, then EBUS TBNA is preferred. 19-gauge TBNA needle is recommended for aspiration. 3 to 4 passes to be done for each lymph node. Endobronchial biopsy. Cup or alligator forceps can be used to obtain endobronchial biopsy. 4 to 5 specimen of biopsy to be taken. For bleeding control post-biopsy, cold saline, adrenaline and tranexamic acid can be used and endobronchial blocker in severe bleeding. Transbronchial biopsy. Alligator forceps is preferred for performing TBLB. 4 to 5 sample to be taken. In diffuse lung disease, biopsy to be taken from bilateral lower lobe. In focal lung disease, biopsy to be taken from segment with maximum radiological abnormalities. Float sign should not be used to ascertain the adequacy of TBLB specimen. Bronchoscopy training. There should be a structured program for basic bronchoscopy training. Minimum of 100 bronchoscopy procedure, 50 supervised and 50 independent to attain competency. 25 bronchoscopy procedure yearly to main competency. Bronchoscopy in ICU. Routine bronchoscopy is not indicated in ICU for ventilator-associated pneumonia. Bronchoscopy in ICU should be done if patient not responding to antibiotic or suspecting alternate diagnosis. Bronchoscopy in ICU should be done in collapse and atelectasis not responding to chest physiotherapy. Bronchoscopy guidance is recommended during percutaneous tracheostomy. Bronchoscopy in patient on mechanical ventilator. For bronchoscopy in intubated patient, the diameter of endotracheal tube should be 2 mm more than the diameter of bronchoscope. During bronchoscopy in intubated patient, the FiO2 should increase to 100% 5 minutes before procedure and tidal volume to increase 100 to 150 milliliters. Inspiratory pressure should increase to ensure adequate tidal volume and PEEP should be kept minimum for adequate oxygenation. Bronchoscopy in non-invasive ventilation patient. Bronchoscopy in mild to moderate acute respiratory distress syndrome should be performed with NIV assistance by an experienced operator and invasive ventilation facilities should be available. Equipment disinfection and scope cleaning. It should be done at dedicated area. Leak test should be performed after every bronchoscopy. Disinfection can be done either manually or automated endoscopic reprocessor. Use of preacetic acid for contact time of 5 minutes, after that glutaldehyde 2% with contact time of 20 minutes and 70% alcohol purge be performed as final step. Thank you. Hope you like the video.